Welcome back to the PAWCast, guys. We got a little bit of a special guest going today, so here we go.
Welcome to the PAWCast.
So we have Rheannon with us today. You are clearly a fresh face to the PAWCast. Some people who are watching may recognize you as they may be your classmates. Who knows? But Rheannon is here on a mentee level on our Tier 3 mentorship. And basically what that is our clinical rotations. And I'll actually kind of leave that description and all that to you, Katie,
Sure.
Because you've been through it. You were pretty much like the one that really pushed the construction of it as well. So what is Tier 3 in our mentorship program?
Sure. So the Tier 3 mentorship is geared toward clinical externships. So veterinary medical and veterinary technician or veterinary nurse students needing to fulfill some of their continued clinical coursework prior to graduation can come and spend one of their rotation blocks with us. At Michigan State, that's a 3-week rotation block. And so we have the student come in, and it's a bit of an abbreviated onboarding, but we still do the TriCore, have an afternoon of onboarding with Annie, and then get you into the clinic seeing patients with myself and Dr. Riolo.
Mm-hmm. And into the shelter, too.
Yes. Yep. And we the goal is by the end of the externship, we actually use our skills rubric and performance review to give you a sense of where you're at.
Mm-hmm. Which you haven't seen yet. That's coming on Friday. Yes. Are you nervous about it?
You guys haven't been mean so far.
All right.
Win.
We weren't planning on it, so.
Well, and I mean, just again, the performance review process is never meant to be mean, right? It's all about growth. So it's just a discussion on here's where we're at. This is where we can grow. And if you if you end up staying within PAW, it's actually outlining, okay, this is how we're going to improve these areas, and this is how we're going to grow and get better.
Mm-hmm. Right. And kind of when we had met last week, too, it was like you're taking all of these things, and I understand how they would transfer into our culture, right? Mm-hmm. But how do we kind of even push that one step further is like, well, if you don't end up in Mosinee, like wherever life takes you, what does that look like outside of this structure, and how can you utilize, not only veterinary skill set, but also some of the softer skills because Rheannon had actually retaken the assessment just to see if she was, how much she had adjusted in the last 2 years, which was surprisingly not.
Okay. I was going to say, I'm always interested because, like I said, I had taken the disc part for the first time in 2008.
Yep.
And then followed it up, 5+ years later when I took it with you guys.
It was 2013.
Yeah.
Yeah.
Surprisingly the same.
Or 2015.
Or maybe not surprisingly the same.
Right. The behavior side has just, I think you probably have smoothed the edges off a little bit.
Yeah, there's
some coaching,
well,
self-awareness maybe. I
think the smoothing of the edges actually came after the second time when I had a better grasp of the whole.
Yeah.
How all three fit together. And yeah, absolutely. So.
Yeah.
Very good.
So Tier 3, though, that was a big part of it. Now, Katie, you described what it was from our perspective and what we built that, as well as 1 and 2 and 4, which we'll get into on a later date. So we had basically a vision from experience and what we thought was missing in the industry and just a number of different influences. And then you show up and what was your expectation without actually, it's probably going to be a little bit difficult to not say what we've put in front of you, but when you've been through, I'm doing rough math here, probably 30 different rotations, something like that, or no, Like 15?
Yeah, that's
15
I
rotations.
think you end up doing
roughly?
right around
20s-ish or so.
Yeah.
Yeah.
So what did you expect coming into a 24-hour all services clinic on a rotational and externship level?
Yeah, so I'm kind of a wing it and see what happens kind of person. I had that schedule sent out to me saying that I was going to be working in the shelter some days, in the clinic some days, some nights leading up to midnight or so, and things like that. So at least the hours worked. I had that concept. Beyond that, just didn't really have expectations beyond that far. But
were there skills that you were hoping to, and I don't improve upon, or at least get exposure to, that you haven't had exposure to yet?
yeah, so a big reason that I wanted to do an externship outside of Michigan State is to kind of get some more real world to it. Not everything is a tertiary referral hospital where you can just throw something over to CT or something like that. So seeing how medicine is practiced in a different area was interesting. Even emergency medicine, where it's not all at your fingertips like at MSU. And then just getting more independence, more my doctor legs under me a little bit. Yep.
As
Yep.
Caroline would say, becoming a more doctory doctor.
Yes. Right. Yes. Because
I'm a very baby doctor.
Right. May 1st.
Yep.
Here it comes.
Yep.
So were all of your previous rotations just at MSU?
I had one, which was kind of surgical and shelter based down in North Carolina, which was very different in that, you're not really practicing the medicine aspect. It was more along the lines of, shelter and then out. So this was one of the first actual based in medicine and practicing medicine and getting those skills on board kind of externships.
Cool. And what are your thoughts? How do you feel about it? If you were to be a doctor tomorrow?
I really liked it here.
You're really close to tomorrow.
I know, yeah. I really liked it here. I like that there is such an emphasis on mentorship because it's hard to always know where your gaps are when you're kind of hand-fed a lot. And at MSU, they don't let you fail. They try very hard to get you to think through all the lists that you need to think through and get your clinical reasoning on board. But it's different when
Sure.
it's a little more hands-off and figure it out, and we're here to help when you have questions, because baby doctors have lots of questions.
The whole concept of fail forward. Right.
Yep. That's a big thing. You gotta be exposed to the elements, because if somebody's just holding your hand and walking you through the forest, like you might notice what they're pointing out to what you don't want to trip on, but at some point you're gonna have to break out the flashlight and start walking yourself, right?
Yeah. And I've noticed that a lot in the last couple of weeks, that I'd start to do something thinking like, yeah, I've done this before, I totally got it. Oh crap, wait. Let me think through this a different way, because I know I'm not totally on my own. There's that support backbone there. I'm not going to fail doing it, but like, oh gosh, do I actually understand this enough? Can I adapt to now like my own reasoning, my own judgment, and see what happens with it? So it's been nice I haven't been allowed to fail exactly, but like to have to fight through a problem that,
Well, you've been provided the opportunity to. I mean, you've had your hands inside of patients. I mean,
yeah.
And it's not like, maybe failure is not the right word, but like to stumble, right?
Yeah.
Like at some point you could have just like, whoops, shouldn't have done that. Like, and that's what you're talking about with the support structure, where it's like, this isn't going to be like the ultimate failure, but like you also weren't being completely guarded from any type of risk.
Yeah.
Like there's definitely some that was included in there, and then walking through cases with Dr. Carlo and Dr. Katie as well, where it's like, all right, here it is, what do you do type thing, and then kind of go from there. So risk, but there's also that safety net, which was kind of the idea from the inception of the mentorship program, and is essentially like, MSU probably puts it a better way than I could, is in creating day one ready.
Right.
You have to be ready to realize the risk of stumbling and potentially failing, and if you don't have that skill set outside of the referral type structure, it's probably, or even just like super specialty within a university setting, it's probably going to be a pretty difficult realization when you step foot into a day practice clinic that's been around for 30 years and just does things the way that they do. So, but you went through that. You said that you had a mentor. It wasn't a mentorship program per se, but you went through the whole thing. And now, with looking back at your experience and kind of the way that we built it, and now knowing Rhiannon's experience, do you see parallels? Do you see differences?
So, and one thing that they have eliminated from the MSU clinical rotations that used to be required was called the your ambulatory externship, where you were assigned to a clinic in Michigan. And it tried to match your interests. So if you were interested in small animal, very often you got matched with a small animal practice versus dairy medicine. I went to the eastern end of the UP to a mixed animal practice where he was a solo practitioner, and his wife was his assistant, and his daughter-in-law was the receptionist. And
man, keeping it in the family.
And that was it.
Yeah,
that was the practice. But for me, and I think I had mentioned this when we were talking, for me, that was one of the best externships that I had been on, because it taught me really taught me the value of a good physical exam, because he didn't have really anything in house. If there were going to be any diagnostics done, they got sent to Michigan State. And so really being able to utilize your physical exam to have a conversation with the caregiver about, this is where we're at.
Yep.
These are the tests I have available, but we aren't going to have results for a couple of days, and where to go from there. And I think those are the conversations that as a student you don't get to have, that you need to be ready to have day one.
Yeah.
Because the minute you start seeing patients and talking to caregivers, you have to be able to say, okay, this is what I found, and talk to them about history, and then come up with a treatment plan. But then not every caregiver is going to be able to proceed with that gold standard treatment plan.
Right.
And make adjustments from there.
Yeah, pretty much every setting outside of that university structure, right, is going to have significant more barriers to that gold standard type treatment,
Right.
whether it's caregiver finances, available diagnostics that are around, like how many clinics around in Wisconsin have a CT?
Right.
Like 3,
Specialty,
4,
right.
5,
Only
right?
the specialty.
Right.
Yeah.
So it's not really something that you have available. Oncology services don't really exist outside of the university setting in our area, right? There's a lot of barriers to all of that sort of stuff. So being able to have I would say that's really just a part of informed consent, is just
Right.
understanding what's in front of you, right? So without actually, and probably one of the biggest values to informed consent, I would say, is understanding those barriers, right? So when we talk about the 3 costs,
Right.
This one's probably, in our situation, pretty heavy on the financial, where we don't actually know what a caregiver's finances are like, and we never can assume positive, negative, or otherwise. So it's like, all right, I have no idea, but this is what you can do. What are you gonna do?
And and just being, and again, at a university or referral type practice, they are already, the expectation has already been set up that it is going to be expensive, right?
Yeah.
They know that.
Yeah.
And then again, coming into the quote unquote real world, there are very, very varying amounts of caregiver expectations from a cost standpoint. And so being able to provide that discussion of a treatment plan and then followed up with an estimate from a financial aspect to allow them to make the best decision for them and their patient.
And you and I actually kind of talked about that last week in a situation that you had experienced that was similar, but on actually like a situation that happens in our clinic from time to time where they didn't expect something to be as expensive as it is. But we handle that on the front end and you had to handle it on the back end.
Yep.
Of like all
It's
of
already
like,
done.
So they walked in with that expectation, but there was still that, oh crap, this is really stressful. So you can kind of tell the tale if you wish of what happened.
Yeah. So typically once they get to MSU, especially one of the specialty services, they understand there is going to be a significant cost. You're not coming through a soft tissue surgery department unless you know you're getting some kind of surgery that only our doctors typically do.
Right.
So this patient was a little bit different in that I think they came in through a different service first.
Sure.
So they were kind of already a little uneasy with the cost of everything. And then, so after the whole workup, you know, these people really love their dog. They ended up removing one of the legs due to a tumor, and they were quoted for a certain amount for the surgery and for the medications and for the hospitalization and all that. And then it just updating the quote and that estimate kind of fell through the cracks. It's a
Gotcha.
big hospital. There's a lot of hands in every bit. It transferred departments, I think, once or twice. So it just kind of fell through the cracks. And then at the end, when we were checking out, their bill was kind of significantly higher than the quote that they had signed for. And then they had specifically told me they were concerned about reaching their max. Through a couple channels, the word just never got to the right person. It just,
Sure.
yeah, fell through the cracks. So they were very surprised at the end of the day at what the final cost was, except what can you do? The dog's leg was amputated and this is the bill now. And it's one of those things where it kind of fell on me at first because I'm the student that's checking the dog out, and now we're in the lobby and there's a couple unhappy things
Sure.
happening right now, and it was just interesting to have to deal with that. And how do you manage that at this point?
Sure.
You know, it should have been a good thing that their dog is now without the tumor and leaving, and
Right. Right.
Just
Kinda
a
soured
bad,
it there.
just a bad period at the end of the
Yeah.
sentence. Which, again, I have never been really outside of PAW on a
Well, and
practice
so
level, but-
I wonder how much of that was a, like you said, like was a breakdown in process, because so I get, from what I remember, and I get we're when the changing service, but when they came in, if they were going to be hospitalized, there was a whole estimate process, and they were provided that. And then each morning when the student called with the patient update, we also had to update them on where the bill was at.
that is no longer really an expectation of us to handle that part of the financial side.
Okay.
We can get them to sign the estimate saying between this and this range, and then from that point on, it's kind of hands off as a student, and we're literally just there to have them sign the paper and get them
Sure.
out the door with that. So when I had met with the people originally, they said, this is my max. I am here for this. This is what I can do. And I relayed that information to a couple of the people that are more responsible for the financial side, and that's where our process kind of broke down and it got a little overboard. I thought it was more I thought it was getting handled a little bit differently. I wasn't checking in on the bill. It just kind of funneled through that.
But
that was the
even
result.
if you were checking in on the bill, you didn't have,
Yeah.
it wasn't anything that you could have updated the caregiver with along the way anyways. That wasn't an expectation
Yeah.
of you. That was somebody else's responsibility that didn't get done.
Yep.
And then you ended up hearing about it.
Right.
Yep.
Which is probably, unfortunately, considering the way that clinic structures outside of PAW are generally set up, I would bet that a lot of students at some point in their practice of medicine is actually going to end up having that conversation.
Yeah.
Right.
Right.
That's not the only time I've had it. That's
Right.
just the most significant. And that one at least was fairly easy to turf over. Where I called my doctor up real quick. Said,
Right.
Please come help me with this. This is out of my range of what I can handle. So
Yeah.
But when you're day one ready,
Yeah.
right, and you're the one that's ultimately like you're that doctor that the technician or the support staff calls, right? Like,
Yeah.
how do you have that conversation? And the hope and the reason that our process is the way that it is you don't have that conversation.
That's why I really like the process here in regards to that with like the upfront pricing and there are not surprises or there shouldn't be. And
Right. So
You can never say never. Medicine is as much an art as it is a science, and surgery for that matter. But part of that process is, yes, the upfront pricing. But if something were to happen during a hospital stay, during a surgical procedure, that is a phone call that does not get turfed to the end of the patient's stay. That is a phone call that happens almost essentially in the moment.
Yeah. We just had one this last Saturday.
Right.
Of there was an unforeseen,
Well,
variable, right?
Right. Whether it's a complication or just something that wasn't accounted for happens.
Yeah. Or
right.
like a potential risk factor that is ultimately realized because the diagnostics are unable to actually source just the liver.
No test is 100%.
Right.
That's just reality. Yeah, again, it should never ultimately end up being a time of discharge conversation. That conversation happens well before we get to that point.
Right. Yeah, so with that experience that you did have, you probably learned a lot of stuff, right? Like, number one, and the funny part is when you were originally telling me that story last week, it was just like, oh, so you just listed off, like, unnecessary conflict entirely.
Right.
And then there was another one, it was like, oh, you're just defining what inefficient process is, all the stuff that we've talked about for too many hours probably at this point on this platform. But it was funny how it completely unprompted, it's like, oh yeah, that. Coming to the guy that has never ever been in that setting on that level. So the big thing that I would take away from that is, number one, you can learn how to have financial discussions, because that's definitely a part of being, a veterinarian, or potentially any doctor for that matter. I don't really know, but definitely in vet medicine.
Right.
And then the other side of that is being able to try and, to get it out in front of it, because that experience is, you can pick one of two ways to go. You can keep going down that path of, I'm going to continuously have these crap conversations at the end of this process, or I can just get out in front of it. So from a transferable skill set and why you're here, right? To get better at being a veterinarian and being more day one ready. That whole point of, kind of rehashing this and understanding how it parallels or doesn't with our process is, you can actually now understand the negatives from that and the positives of what we recommend, right? And you can take that into any clinic. That's
right.
The whole point of tier 3, is you can now take a very specific skill set that you are not getting in school, which potentially, not to the fault of the school.
Right.
Right. They have their way of doing things. It's not like they're doing something so badly that we need to say that they're terrible at it.
No.
But there's differences. There's pragmatism within real veterinary medicine outside of that structure. And that's one of the ways to really understand the value of having that conversation on the front end.
Yep. And going through clinics, I've been through enough rotations. I've had difficult conversations. I have learned a lot of that aspect of it in school as well. It's just different having it done here and just seeing how the process helps you avoid those.
Right. Yes. What else did you learn? You did some surgeries.
Yeah.
What about like actual tactile skill sets? Was that something that you had before?
Not nearly to this degree.
Yeah.
Just a lot more hands-on, and it's really great because it feels like there's more trust in that. Like, especially for the first several of them, you know, Dr. Carlo would be in the room watching, making sure that, you know, giving tips along the way, making sure that I was not going to mess up.
Mm-hmm. Right.
And then it kind of crept back, like a little more hands off. Like, I know you know how to close now. Yell if you need something. I'm in the other room working on this, but like, I believe in you. You got this.
Mm-hmm.
Like, great. And a lot of the time with that, it's just repetition. Just do it again and again and again and again until it feels right in your hand.
Mm-hmm.
Right.
So
creating that muscle memory.
Yeah. So that has been helpful to start to develop. Because I think I said something to him sometime last week, like, it feels so much less foreign.
Sure.
To be closing this right now.
Mm-hmm. That's pretty cool.
Yeah.
So I was there that day, just not, just I was working on something else too. And I was like, oh, she's just doing it. Like, she's just doing the surgery thing. So that's pretty awesome.
Yeah.
And yeah, you didn't, at least in the time I was there, it was like, no, you just went through the motions, and it was like, you were just being a doctor, which you didn't have 3 weeks ago. Really. I mean, you probably would have been able to work your way through it.
Yeah.
But it's that's pretty cool.
Yeah, but to be able to go in with that confidence, with that additional confidence, again, day one versus having to kind of struggle through trying to gain that your first 3 weeks of like at a job.
Mm-hmm.
Yeah.
That's going to make a huge, like, as you're overwhelmed with all of the other stuff that, like, starting a new job could potentially bring on, like, that's one less thing.
Just one less thing.
Right.
Just knocking them off the board, right? Because there's a lot of things.
There are a lot of things as a baby doctor that it's like, ooh, okay.
Baby doctor, I love it. What else have you been working on? I was gone for like 5 days of it, so I didn't actually get to see your first few days.
Yeah, the first few days was kind of an easing in period. The very first day with onboarding, and then I think one of the next days I just shadowed some CVTs and got a feel for the clinic and the process that you follow here.
We went to the Humane Society because then that's right before.
Right before we left
the trip. Yeah.
Mm-hmm.
Yeah.
Mm-hmm. So also went to the shelter and saw all of that, and all those charts keep showing up, and the core values and all of it just it's reinforced constantly, which is I appreciate, because to me they make sense. It's a logical flow, and it's nice seeing what makes sense actually work as well.
Sure.
Yeah.
Yep.
There's definitely, because you can read I've read a ton of books and like take like 30% of it and you can just throw it right in the garbage because none of it's actually realistic. That was the whole point of the ERT in going from like the one page in the front, because if you were not aware, section 1, page 1 used to be its own section, which was the core values surrounding serve the patient, and now it's between 1.1 and 1.2 it's like 30 pages, but that was the whole point, was taking something that is very, very usable and putting it in the hands of everybody else, and that just expanded pretty substantially in the last year.
Right.
But yeah, I'm glad that that's being translated well, because I freely admit that I have consumed all of the PAW Health Kool-Aid. I may be brewing it up myself at this point, but I'm glad that that's working.
Selling it in the lemonade stand at the
just right off the highway. Come drink. Here's the lemonade, guys. Big old 11,000 square foot lemonade stand. Oh, nice.
That's part of why I came out here. Is I think it really just came down to one lunch meeting that Carlo was at, and I'm not even from this area.
Right.
And then here's this guy just speaking with passion, and it seemed like it made sense. I clearly don't remember everything that was talked about in the lunch meeting, but it just kind of stuck in the back of my head. Like, maybe that is a new way that they could try to do something. Maybe I'll check that out. And then I get here, I actually, put to words and actual process and see what the things that he was talking about that seemed exciting at the time, like that they actually work and that I understand kind of how it flows now. And yeah, good decision.
And it probably actually makes more sense now that you've been through several clinics and you're getting ready to start looking for a job, as far as setting those expectations about, one, what you are looking for in a clinic, as far as what they can provide both in patient care and like culture within the employees.
Yeah, and I like to learn from everything. I like to ask why a lot and figure out why things are being done the way that they are. Part of wanting to learn everything, I'm learning a lot of things that I don't want to do, not here necessarily, just throughout, my range of experiences, picking up things I like and things I don't like, and I'm seeing a lot of things I like here, so it makes sense to try to find, even if I don't end up here, like a clinic that follows some of those.
Right.
I hope you're ready to make it. Not just walk into it.
Right. I mean,
that was actually one of the most eye-opening things for me when we were at MSU, and actually mostly at the conference, because we were like, everyone was like, what are you trying to sell? An idea. And some people would have that similar response that were the ones that were already practicing of like, this sounds like something that would be of value. But it was probably like 30% of the people that we even talked with, let alone the bunch of people that walked right past us. Right. Which was fine. We understood that that's not who we were there for anyways. But the few people that it really like latched onto, you could tell they were like, I don't know what I'm going to do with this, but I'm going to do something with it.
Right. It's like 2 years ago, and now I'm here.
Yeah. So, but the cool part about that is understanding actually what we had talked about in the last podcast with Carla and myself is really just being that agent of change and understanding that the majority of people that are going to be around you are actually going to resist and potentially try and be a barrier to you creating this type of change. There are going to be a lot of forces that are going to pull you back in or try to pull you back into the center of the way things already are. And over time, somebody has to be the force of change. That's why we put it on so many things that we do. And this is the whole point of the mentorship program as well, is to start to find people like yourself where it's like, I love to ask why. I want to be, understand what I want to do and what I don't want to do and how I want that to be completed as well. And that's how that web starts to grow. So you now going out into the world, again, not really sure where that's going to take you yet. It's like, all right, well, let's make sure that you're ready to understand the fact that there are going to be about 80% of the people that you're around, they're going to be like, that's a dumb idea. You shouldn't do that. But you've already seen it happen, and you know it's a good idea.
Yep.
It's frightening, though, for a lot of people to understand that there is literally just a wall of people kind of in your way to making that happen, but it's worth it. So, sorry, don't mean to like burst your bubble there, but
change. I mean, just change is difficult.
Right.
I mean, we experience that even within PAW, though. So it's not that. I think most of us have drank the Kool-Aid.
Oh yeah.
But even then, we can kind of get to a wall, and it's like, okay, how are we going to kind of get over this hurdle or break through this wall? What's the next step? And we often will find resistance if the change is big enough, and it's just a matter of sticking to the core values, really. As corny as that sounds.
Right. Well, because ultimately, like, if the old way is better, like we've gone back to the way things had been.
Right.
But it's like, well, we don't know until we try it. So why not just try it? We're all here for the same reason. Why not just see if we can do it better? That's
Right.
the whole concept. But again, that is a mindset that some people will never have.
Correct.
I think a lot of people have a hard time with just the throw it out there, you know, and see what you catch type thing. But doesn't sound like you really have that problem. Is, you know, like, yeah, whatever. If there's a better way to do it, why not know about it is kind of the mindset. Because it's not only in, you know, the business aspect and creating change on a cultural level, but also from a medicine perspective. Like, that's what science is.
Right.
So, I guess I don't have another question myself, Katie. Do you have one? I'm running dry.
Well, that's so from an experience from the last 2.5 weeks, we've talked about kind of just process, fitting like clinic culture, skills. So surgical skills, any other skills that you feel that were
Enhanced?
like, yeah.
Better?
Yeah,
Improved upon?
I really like the emphasis placed on informed consent.
Sure.
Just getting through all of those conversations, it's great to go in the room and just hear it again and again and again, and how thoroughly it's talked through. Other times that I've had to have these conversations, it's kind of a barrel through of, this is the problem, now this are the next step, and at the end result you'll get to this, and that's that, and there we go. And here we are. There's less emphasis placed on, well, what can you manage? Can you catch your outdoor cat and give it heart failure meds 2 times a day? Is that good for you and your family and your cat and
Sure.
your budget and all of that as well? And all of those factors play into the ultimate goal. You know, we can say all we want, this is the plan and this is how you get to this outcome, but like, is it going to happen? So I like how there's a variety of options placed out there for the caregivers to decide what works for them, and how little pressure there is to steer them one way or another.
Yeah. So I think what you're hitting upon is, especially at that like referral level center, and oftentimes you get caught in that trap in private practice as well, where you're there serving the patient, but you kind of get blinders on as to what that means, right? So here's a patient in heart failure. You need to give these meds 2 to 3 times a day, and that's what it is. Here's your meds. And they come back for their recheck 3 weeks later, and they aren't doing as well as you wanted, and you find out, well, the caregiver isn't giving the meds as directed. And then it becomes this frustration. Well, why aren't you doing this? Versus having that upfront conversation right away. So we need to give these meds 2 to 3 times a day. Is this something you are comfortable doing? Is this something that you can realistically do in your patient? What does it mean if you can't do it? Because then that brings into the conversation that Ben alluded to or a little bit earlier, that we do bring into the informed consent part of it, is the 3
3 costs of patient care?
right.
Yeah.
The 3 costs of patient
Right.
care as far as physical, financial, and emotional.
Right.
And that's a big part of patient care, and educating the caregiver. And I think that's the part that is, that's the most difficult part of the conversation to have. And I think it gets kind of pushed aside a lot of times.
Yeah, it's less singly tracked
Right.
towards the outcome that we want for the patient, and more, all right, what actually can we do here?
Right. Yep.
Interesting. Is there anything that you feel like we missed on?
Ooh.
Because as much as we want you to improve, guess who else wants to?
Right. Yep. It's a 2-way street. That's for sure.
I'm not sure. nothing's jumping to mind, but like, can I get a performance review to you guys too after you do me? Like,
Yeah.
Yes,
Yeah.
absolutely. I would very much appreciate it
I can
because
do
it's
that.
really right. Like you walked in with, even if they were unwritten, but with a certain set of expectations of what are you walking into, unspoken or otherwise. And for us, we want to be able to fulfill, those as best as possible, which is why we try to set those expectations right away. But yeah, really, yep, absolutely. If there's any sort of feedback, as much as we love to talk about the positive feedback and how, we're doing as much as we can and effectively creating, a greater skill set for you, with you, that's the right word. It's also good to know specifically where we can do better because you're not the first and you're not the last, right? There's one of your friends is right behind you. So, I'll be curious to gather that feedback and see what we can do with it because I would very much appreciate it.
And I guess a similar, but just a little bit different because we do have you here for a few more days. Are there any skills, and this could be specific to you, but just, and your schooling, are there skills that you feel that we could have helped you with that we didn't kind of get to with the kind of caseload or patients that were presented? And that's going to vary for us too, because we have to deal with whatever presents
Whatever
itself.
walks in the door.
Yeah.
Right, presents itself to us.
Yeah.
But
yeah, even on that one, it's a lot of the things that I wanted to work on have been touched on in some regard.
sure.
And even when, back my first week, it was a little more of a passive role. I would go in and just listen. And then this week or a couple of days ago, I saw a case myself and I did all the client communication and, Dr. Carler was there to bounce ideas off of and make sure I didn't, go down any wrong trails.
Right.
So everything's been touched on and it's been improving.
Sure.
So
Yep.
just confidence and keep doing it.
Is that the plan for the rest of your couple days here is to just do doctory stuff like on the floor? I don't know what the plan is.
No, the plan got,
Got a
I mean,
little-
welcome to PAW Health. The
Yeah.
plan changes,
Yeah, be ready for change.
right? So we switched her schedule around a little bit. So we've got the staff meeting tonight. So we'll get to have kind of that experience of the entire staff in one room. And then I think tomorrow is an off day. Friday is performance review, a couple hours on the floor with myself, and then finishing out with you instead of.
And with Annie, I believe. Or no, that's
That's gonna be
beforehand.
in the morning.
Man,
Yep.
I get to just close it out.
Yep.
Oh, we get to do that stuff we get to do some marketing stuff. So you get to talk about yourself in a much more short format, a little bit. Did you get those questions, by the way? Totally non-necessary to this conversation, but
Maybe I haven't checked.
fair enough. Cool. Well, yeah.
She's been a little busy. She
Yeah.
got called
I
in
respect
this
that.
morning at like 4 a.m.
Yeah.
So she's been.
Oh, you got to jump
I've
in
been
on that
finding
surgery
things
this
to
morning?
do, even if I don't have more scheduled
Yeah.
real shifts, that many more on the floor here. I've found my way into that clinic a couple times
Fantastic.
outside of normal hours, just because there's cool things I can get my hand in.
Yep.
Cool. Yeah, there's definitely, it's always at 4:00 in the morning though.
Yeah.
That's when the weird ones come in. So, I'm glad that we were able to do our part. And I look forward to hearing how we can do it better. But we don't need to take your whole afternoon. I know we did wake you up from a nap to do this, so.
4 a.m. calling.
Yes, absolutely. We can kind of, unless you have anything that you'd like to continue on, Dr. Katie, we can keep this as kind of a short one. Rhiannon, thank you for joining us and being a little bit uncomfortable with cameras and microphones and all that sort of stuff and muscling through it anyways. So, all right, we will be back next week. Have a good one, guys.